Hi, Vikas. Hello. Can you guys hear me? Arif, can you hear me? Arif?
Yes, sir. Yes, sir. We can.
You can hear? Okay, good. Yeah. Hi, Vikas. Are you there?
I think, sir. Yes, sir.
Okay. So, Vikas, I will hand over I'll wait till 5 o'clock and then I'll start recording and then I'll hand over to you.
Yes, sir.
So, how was the lecture this morning? There was cardiac morphology, isn't it?
I was in hospital. I could not attend.
Oh, you were busy today. Is it Saturday working day?
Yes, sir. We had one CABG today.
Oh, Saturday you guys take it easy. We don't.
Saturday is a working day for us. Generally, it is vascular case.
Oh, I see. So you still do vascular work as well?
No, vascular unit is different here. Old hospital we used to do. Mission hospital we used to do all kind of trauma, popliteal, this thing, that thing, femoral. But here it is a different unit.
Are you guys are involved with the endovascular work as well, or as the radiologist?
The vascular unit. No, vascular surgeon is there. He does. Dr.
He does the endovascular.
Yes.
Shouldn't give up to the radiologist.
No, not radiologist. In our hospital, not radiologist. It is surgeons.
Yeah, absolutely. It's a very, very large chunk of.
Yes, sir.
You must keep your stuff. And it's very exciting as well. Endovascular work is very exciting.
Yes, sir.
So we will Wednesday we will schedule your mitral lecture. So that should be fine.
Okay, sir.
And then in the next couple of weeks we'll try and cover the tetralogy of fallow, ASD, ASD. How long will your mitral lecture take? Will it take 2 lectures?
Yes, sir. In one we'll do mitral stenosis and surgical aspects. And second one, mitral regurgitation, ischemic mitral regurgitation, mitral valve repair, and other things.
Oh, fantastic. That's good. So 2 sessions we'll keep. So,
yes, sir.
So you want to do it on a Wednesday? You're happy with that, or you want to do it on the weekend?
Anytime, sir.
Okay.
You decide according to your schedule, sir.
Yeah. No, it's not a problem. Late evening for me after 5 o'clock is okay. So
yes.
But very much in control. In the UK, we are very organized with our times. So we don't do crazy late hours. Okay, so we've got about 4 minutes more. So just we've got a lot of people coming up. It's going to be an interesting talk. ECG is something that everybody thinks they know, and then everybody doesn't know.
ECG achilles heel for surgeons, sir. Despite being involved with cardiac surgery day in and day out, ECG is one point where we depend heavily on the cardiologist. We always go and consult what is this, what is that.
Today, I am hoping that it all becomes clear for you.
Yes, sir.
I will try and attack the basics of ECG so that you get a good concept of the physiology of why each thing happens, and then it becomes clear. So
yes, sir. Yes, sir.
Okay. All right. So I am ready to hand over the hosting to you so that I can start recording.
Yes, sir. Yes, sir.
First, I want to let me first record on this computer. Then I share screen. I want to share my second screen. So can you see a blue screen?
Yes, sir. Blue screen.
Blue screen. Okay. And then the third thing that I want to do is to hand over. Just where are because okay, have you got the hosting now?
Yes, sir.
Okay, so you take care of the people who want to log in.
Yes, sir. Yes, sir.
then I will focus on the lecture. You can see my first screen?
Yes, sir.
Because just give me a quick feedback that you can see so that I know.
Yes, sir. We can see, sir.
Yeah, I just need to know I'm not talking to a blank screen. Okay, just a couple more minutes and then we'll start the lecture. 2 more minutes for 5 o'clock and then we'll start the lecture. Vikas, can you see the recording thing on your screen?
Yes, sir. It is recording, sir.
It is recording, isn't it? That's
Yes, sir.
the most important. We need to save this. Okay, good evening, everybody. Welcome to the next lecture in the Thoracic Guru's online teaching education program. Today's lecture is on the basics of electrocardiogram, the ECG. A lot of people either they think they know the ECG or they are worried about the ECG. And even I know a lot of cardiac surgeons who operate day in and day out on the heart, but actually struggle with interpreting an ECG. It will be a surprise for a lot of non-medicos, but the reality is ECG is something that a lot of people are not very clear about the fundas of ECG. So today when I'm going to discuss ECG, I'm going to talk about basic physiology, take you through a few basic things, and then go on to interpreting an ECG. Again, the first part of the lecture is more important than the clinical side. The understanding the physiology behind the ECG is absolutely mandatory. And once you understand the physiology, then the rest, the clinical interpretation comes naturally. Okay, so don't worry about it. But focus very hard on the first 1 hour of the lecture, where I'm going to talk about the physiology of ECG, what exactly is happening, and how each of these graphs are generated. Okay, so also make sure you have a pen and paper with you so that you can jot down some important points. So whenever we start talking about ECG, before we can talk anything about the ECG, we need to just brush up a little bit about the cardiac muscle action potential. We spoke about this in our last lecture when I discussed all the cardiac graphs, but just because we're going to discuss ECG, I want to just revise the cardiac action potential before we go on to doing the ECG. So let me start off by showing you the action potential, and the resting membrane potential in a cardiac muscle is anywhere between -85 to -95. So around -90 millivolts is the resting membrane potential. What happens is the sodium and the calcium channels open. When the sodium and the calcium channels open, the depolarization phase starts. So sodium and calcium start to move out of the cell. The depolarization stage starts, which goes all the way up here. So the phase 0 is the depolarization, and then at the apex of the depolarization is the phase 1. At this stage, the sodium channels close, so all the calcium channels are still open, but potassium channels start to open at phase 1. When the calcium and the potassium channels open, there is a equilibrium state. So from a minus stage, you reach all the way to positive because you're throwing positive ions out of the cell. So the cell, which is negative, is now reaching a peak phase, which is phase 1. At this stage, the potassium channels, the calcium channels continue to stay open. The potassium starts to move into the cell. But because calcium and potassium movement is balancing each other out, so there is what is called as a latent phase. So phase 2 is a latent phase. At this stage, the calcium channels start to close and the potassium channels move out. And so you get this rapid repolarization phase. So from a positive, you are coming back to negative, and then you get to your basic resting potential because of the leaky potassium channels. Okay, so this is phase 4. Phase 0, phase 1, phase 2, phase 3, phase 4. The important concept in this is called as a refractory period, which means if there is a second stimulus which will come to the myocardium, it will not generate a second action potential in this phase. This is just the basics. Today, the talk is not on action potential, the talk is on ECG, but very often during the talk, I will use the word depolarization and I will use the word repolarization. And I want you to imagine this picture that is happening. Whenever I talk of the word depolarization, I want you to think of phase 0. And when I talk of latent period, I want you to think of phase 2. And when I talk of repolarization, I want you to think of phase 3. I will be using these 3 terms quite a lot during today's talk on ECG. Okay, so let us define ECG. The bottom line is a lot of people don't understand what exactly is an ECG. So the definition of ECG is it's a graphical representation of the electrical activity of the heart. Okay, so whatever is changing within the heart, the positive, negative, and the movement of action potential from one cell to the next creates an electrical impulse. And what you do is you put these electrodes on the chest wall, and the electrodes on the chest wall, they calculate the movement of that electrical activity. And that movement is represented on a paper as a vertical or as a positive or a negative deflection. Okay, so this is a graphical representation of the electrical activity of the heart. So before we talk about anything in the ECG, you have to understand the concept of vectors. Now, to understand the concept of vectors, imagine this blue box is like a cardiac muscle. Okay, if this blue box is a cardiac muscle and you put 2 electrodes, a negative on one side and a positive on the other side, when the action potential reaches from the left to the right, so when one cell starts to show action potential, it will then stimulate the next, then the next, then the next, then the next. So the direction of this action potential is towards the positive electrode. Whenever the direction of action potential in a cardiac muscle is towards a positive electrode, you get an upward deflection. Okay, that's the important thing. So if the direction is towards the positive electrode, the deflection will always be upwards. It's a positive deflection. This is the most important principle of ECG. If you understand the first 2 slides, I promise you the next whole lecture will become absolutely clear. So whenever the positive moves from cell to cell, cell to cell, cell to cell towards the positive electrode, then it gives you an upward deflection. That is the first principle of an ECG. If you reverse it and you go into the negative direction, which means that the repolarization happens this way. So if the movement is from positive to negative, then the deflection is always away. So whenever there is an away deflection, it reproduces a downward deflection on the graph. Okay, So any movement towards a positive terminal, it is the positive terminal that's the most important. So any movement towards the positive terminal gives you an upward deflection. Any deflection away from the positive terminal gives you a downward deflection. And these are the two basic principles that you have to understand when you are trying to interpret an ECG. The third situation could be that this movement from A to B could be either slow, because normally action potential is pretty rapid. It moves zoop from right to from left to right. But if it is a slow movement from this end to this end, or if the movement is vertical to the axis of the positive and negative. So if there is a vertical movement to the axis of negative to positive, then it gives you a flat line. Okay, so there will be a flat line. This flat line on this thing indicates that either the movement of the action potential is very slow, so it is not creating any deflection, or it is moving vertically to this axis. And whenever these two conditions are satisfied, you get a flat line on the ECG. Okay, so whenever it's a slow movement or it's a perpendicular movement, you get a flat line on the ECG. Have you understood this first three slides? This is very, very, very crucial to understand the whole talk. Just give me a response, yes or no, quickly.
Yes, sir.
Okay, so now whenever there is an action potential, we know that action potential is originated into the sinoatrial node. That is the first one that gets stimulated in a heart. Once the sinoatrial node gets stimulated, it passes the action potential to the atrial muscles. Atrial muscles are thin muscles. They are not as thick as the ventricular muscles. And so the conduction from the sinoatrial node will come from sinoatrial node through the atrial fibers, and then will come to a structure called as AV node. In the AV node, there is always slow conduction. So from sinoatrial node to the atrium is a fast conduction, like a normal myocardial muscle. But the structure of the AV node slows down the conduction. So there is a slow conduction in the AV node. The conduction then moves down the common bundle, which is called as the bundle of His. The bundle of His divides into the left bundle branch and the right bundle branch. Now, we all know that the left ventricle is thicker. So left ventricle takes priority over the right ventricle in depolarizing. So first, as soon as it comes to the AV node, there is a slowdown of the impulse. The impulse will then move down the bundle of His, will activate the left and the right bundle branch, which will start to activate the septum, the interventricular septum. And because the interventricular septum is thick on the left side, the activation always happens from left to right. On the interventricular bundle, interventricular septum, the activation is always left to right. And then it moves forward towards the apex. Then along the apex, the activation goes up the left side and goes up the right side of the ventricle. So left ventricle, right ventricle, and then it goes back to the base of the ventricle. Okay, so we'll talk about this in more detail, so don't worry about it. This is just the first slide talking about the wiring of the heart. It is important to understand each of these because the deflections change when there is a disease in any one of these structures. Okay, so now before we talk anything about leads in the ECG, I want you to believe me that the lead that we are going to first talk about is a lead called as lead 2. Okay, so if this is your normal orientation of the heart, and remember we are looking at it in a vertical section. So you have made a vertical section of the heart, and if this is the normal orientation, lead 2 is a lead which is attached in such a way that the negative is here and positive is at the apex. Lead 2 is the one which has the best access to the movement of the action potential down the heart. Okay, so this is a very important lead to understand. Most of the changes, if you want to look at, you should first concentrate on lead 2. We're not talking about the leads just as yet. We're just talking about positive and negative. So in a lead 2 of an ECG, the positive is towards the apex of the heart and the negative is towards the top of the heart. Okay, so this is called as the apex of the heart, as you are aware. So this is positive and this is negative, and we know that the action potential and the activity of the action potential comes down this pathway, as I showed you in the previous slide: SA node, atrium, AV node, bundle of phase, and then down to the ventricle. Okay, so lead 2 gives you the best representation of changes in an ECG. So whenever you want to understand an ECG, the best lead is lead 2, because that is the most upright lead that gives you the answer. So let's look at SA node. Okay, so SA node has fired. There is electrical depolarization, and we have these leads. We have the lead 2, which is positive here and negative here. The impulse is going to travel from SA node via the muscles of the atrium to reach the AV node. So there will be multiple impulses traveling this way, this way, this way, this way, but the net vector of impulse will be from SA node to AV node. This is the net direction. What I mean by the net vector is when you've got multiple arrows, then you have to take an average of all the arrows. And the average of all the arrows is this red arrow. So when the movement happens from SA node to the AV node, the direction of movement is towards the positive. Can you see that? This is towards the positive. So what will happen when the direction of movement is towards the positive terminal? There will be a vertical movement of the electrical activity. So the graphical representation of this electrical activity will be positive, an upward deflection of electrical activity. Whenever there is an upward deflection of electrical activity from the SA node towards the AV node, that is called as P wave. So the P wave represents atrial depolarization. Did you understand this concept? Yes or no?
Yes, sir.
Yeah, is it clear? The net vector is the key thing. So the net vector is moving from SA to AV. So there is an upward deflection and we call it P wave. It is just a name. We've just given a name. You could call it anything you like, but a standard nomenclature, we have called it as P wave. So what P wave represents is depolarization of the atrium and movement of the action potential towards the positive of lead 2 in the heart. Is this clear? Okay. So let's now look at AV node. Now your action potential has gone here and it has reached here. The moment it reaches the AV node, I told you that the structure, the histology of the AV node is such that the action potential, the electrical impulse slows down. Unlike the myocardium, which have multiple cells next to each other, and they are very quick to move from A to B, the AV node is dense and fibrotic, and it will not allow the action potential to move very fast. So there is a slight slowing down of the action potential in the AV node. The slowing down of the action potential in the AV node, when you look at it from the positive of lead 2, it gets represented as a flat line. Okay, so whenever there is slowing down of the action potential in the AV node, that is actually a flat line. And that flat line on the ECG gets represented as the PR interval. Okay, so this does not move towards the positive, it just staggers in the same area, and there is slow conduction in the AV node. As a result, the electrical activity in the ECG is shown as a PR interval. Okay, is that clear?
Yes, sir.
Yeah. Okay. So now we've said that. So slow conduction, 0.1 second delay from AV node to the bundle of haze. No vector gets generated, so you get a flat line. And so AV node, the PR interval on an ECG represents the slow AV node conduction. Okay. So now we have gone from P to PR. So there is a vertical deflection. Now there is a horizontal flat line. Once we move from the horizontal flat line, the next area that will get stimulated is the bundle of haze. Okay, the bundle of haze quickly stimulates. This is now fast moving, and it comes down predominantly the left bundle, also the right bundle, but the left has more activity than the right. So always the one which has more activity is represented on the ECG. And as soon as the left bundle is activated, it moves the action potential across the septum. And the movement across the septum is always from left to right, left to right, left to right. Okay, so it comes from endocardium all the way to the right endocardium. So the left endocardium, so it moves from left to right. So when this movement is left to right in relation to the positive terminal of lead 2, the net vector moves away from lead 2. Does that make sense? The left vector will move away. So interventricular septum is actually a movement away from the positive vector of lead 2. Hence, you get what is called as the Q wave. So the Q wave actually represents septal depolarization. Is this clear?
Yes, sir.
Yes, sir.
Is it making sense what I'm saying? Do you want me to slow down?
It is fine, sir.
Making sense.
Okay, so we got the P, we got the PR interval, we got the Q wave. Now the next thing to happen once the septum has been excited and depolarized is the ventricles to be depolarized. Okay, but the moment the ventricles start to depolarize, the movement is this way. But the left ventricle is a thicker muscle than the right ventricle. Okay, so left ventricle has higher electrical activity than the right ventricle. So the net vector of the left ventricular activity in this area plus the right, so there are multiple arrows which are going this way, this way, this way, this way. But when you make a mean vector or a net vector, the net vector of depolarizing the myocardium of the ventricle is always towards the apex. And when the net vector is towards the apex, it means it is moving towards the positive terminal of lead 2. And when it moves towards the positive terminal of lead 2, it creates an upward deflection. And that upward deflection is represented on the ECG as the R wave. So the R wave represents ventricular muscle depolarization. Did this make sense? Hello?
Yes, sir. Yes, sir.
Yes.
quickly come back so that we keep the rhythm going. Okay. So the R wave represents the ventricular muscle depolarization, and the net vector of the R wave is towards the positive of lead 2. Now, once this part has been depolarized, the action potential moves towards the base of the ventricle. Okay. So the base of the ventricle, from the apex to the base, that direction is against this. Okay, it's going towards the base this way. So once that happens, the net vector starts to go away from this positive. Okay, so it is all depolarization. We are still in the phase 0, and we are coming down, action potential, action potential, action potential, coming down, coming down. We've got this, and now we are going back towards the base of the heart. And the moment you go towards the base of the heart, the net vector starts to move away from this positive of lead 2. And the moment it moves away from the positive, it creates a negative arrow, a minus electrical representation. And that minus representation is seen on the ECG as a S wave. So the S wave represents ventricular base depolarization. Does that make sense? So
Yes,
we've done the P, we have done the PR interval, we have done the Q, we have done the R wave, and now we have done the S wave. Now what has happened is the whole of the heart has gone through the action potential. It has depolarized. Everything is positive. Now the time is come for the switch from the positive to the negative. Okay, but before the positive can switch to the negative, the action potential has what is called as a latent period. So there is a long period between the switch from the positive to the negative, which represents on the T wave as no electrical activity or isoelectrical activity. And when there is an isoelectrical activity before the repolarization is happening, that will give you a flat line. So now you are going to get a phase of electrical activity which will be flat. And that flat line, when you look on an ECG trace, it represents the ST segment. So ST segment represents the latent phase of change from depolarization to repolarization. Okay, so now we are at a phase where there is no electrical activity happening. So a positive myocardium is going to now switch into the negative, but there is that little lag which gets picked up as an ST segment on the ECG. The moment the ST segment is finished, the myocardium starts now to become negative. So all of this positive charge, which is there on the surface, will switch to negative. Okay, and negative will start moving away from that terminal. Okay, so if this is your lead to positive terminal, the negative, the repolarization actually moves from positive to negative. And when negative moves away from the positive, it again gives you a positive deflection. This is something you have to understand. So when a positive moves towards a positive terminal, it gives you an upward deflection. When a positive moves away from a positive terminal, it gives you a downward deflection. But when a negative moves away from a positive terminal, it gives you an upward. It's reverse. So understand that now the myocardium has become negative. It is depolarizing. So the movement from positive to negative away from the myocardium gives you a positive deflection. And that is represented on the T wave, on the ECG as T wave. So the T wave on an ECG stands for ventricular repolarization. Have you understood this concept?
Yes, sir.
Yeah, it's a negative which is moving away from that terminal. So the moment the negative moves away from the terminal, you get what is called as ventricular you get an upward deflection, which represents itself as a T wave, and the T wave is called it stands for ventricular repolarization. Okay, so just to show you the whole bundle again, so SA node, AV node, bundle of his, left bundle, right bundle, and you have two fascicles of the left bundle called as anterior fascicle and posterior fascicle. And this is important to know because the ECG can very clearly tell you if there is a bundle branch block, if there is a left bundle branch block, if there is a right bundle branch block, if there's an anterior fascicle block, if there is a posterior fascicle block, if there is a block of the bundle of His. Because whenever there is a block, there is no movement of electrical activity across. And then that changes the graphical representation on an ECG. So it is important to remember this structure. At this moment, we are not doing the depth, the clinical side of ECG. At this moment, we are just trying to understand what is the anatomy and what is the physiology and what is the electrical activity. So it is important to understand vectors. When you understand vectors, that is when you understand what is happening on a normal ECG. So P wave, which is a positive reflection on the ECG, represents atrial depolarization. The PR junction, which is a flat line, represents AV node, a slow conduction in an AV node. The Q wave, which is a negative deflection on an ECG, represents septal depolarization. The R wave on an ECG represents the ventricular muscle depolarization. The S wave on an ECG represents depolarization of the base of the ventricle, the base of the heart. This is anterior and apical areas, anterior, lateral, and apical areas. This is the base area, the base of the heart. The ST segment represents switch or a latent period between the depolarization and the repolarization. The T wave represents the repolarization of the heart, but negative moving away from the positive terminal. And the last thing that you also see on an ECG, on a normal ECG, is something called as a U wave. Now, the significance of the U wave is not really clear, to be honest, but some people say that the U wave, the vertical deflection, may actually represent what is called as a repolarization of the Purkinje fibers. Purkinje fibers are special conducting fibers within the bundles. And these, the repolarization change in the Purkinje fibers, may be represented by the U wave. But at this moment, that is still uncertain. So you don't see a U wave in all ECGs. You may see in some ECGs. And if you do see a U wave, it might be normal. You do not have to worry about the U wave as much. So this is all the parts of the ECG. It is very, very, very important to understand each part. What is PR? What is QRS? What is QT interval? What is ST segment? The reason why it is very important to know these parts is because if there is prolongation of a PR interval, that means there is some block which is stopping the conduction of the action potential from the atria to the ventricle. And usually the blocks will be somewhere in either the AV node, bundle of His, or right or left bundle. So a prolonged PR interval will suggest that you may be dealing with a block of AV conduction. If you've got a very tall P wave, if it has got a large spike on a P wave, it might suggest that there is a lot of muscle on the right and the left atrium, and that happens in right atrial or left atrial hypertrophy. Okay, so when you get a large enlargement of the ventricle, of the atria, then you might get a large P wave. If there is hypertrophy, for example, of the left side of the heart or left ventricular hypertrophy, the upward spike will go up because more muscle means more electrical activity. So purely by looking at normal ECG and then understanding the change in the height of the positive and the negative deflection, you can actually gauge what is happening at the myocardial level. A change in the ST segment usually represents ischemic activity. The presence of any problems with Q wave represents septal activity. So understanding where each part of the ECG is coming from actually gives you a very good clue how to diagnose clinical diagnosis purely on the basis of ECG. Okay, so this timing is very important, and we'll talk about timing in a bit. But first, we've got to understand what is happening at a physiological level at each of the myocardial cells. Is this clear? Have you understood the concept so far?
Yes, sir.
Yes, sir.
Okay. Now let's talk about leads. Okay. A lot of people talk about leads and they think, what the hell are these leads? Now, there are 12 leads. Now, why do you need so many leads? See, remember, the ECG is actually just a flat line. Okay, it's a flat 2D structure. So when you have one graph, which is showing your 2D representation of a 3D structure, the heart is a 3D structure. All electrical activity is happening is 3D. Okay, but if you use only lead 2 from positive to negative, you will just get one horizontal flat 2D representation. So we want to recreate the heart in 3-dimensional. So to recreate the heart in 3-dimension, it is important to move that positive negative terminals around the heart. You have to swing the terminals around the heart. And the swinging of the terminal around the heart can be done by using 12 leads on the chest. Okay, and how are the 12 leads calculated? Well, there are 3 bipolar leads. Bipolar means there is a positive and a negative. So the 3 bipolar leads that are present is lead 1, lead 2, and lead 3. Okay, forget where these terminals are. First, just understand that lead 1, 2, and 3, they have a positive and a negative. Now we also have, to further give you more orientation around the heart, we have 3 augmented leads. These are called as unipolar augmented leads. So these have only positives. And the positives use the heart muscle, the center of the heart muscle, as a negative. And so these are called as AVR, so augmented lead right, AVL, augmented lead left, and AVF, which is augmented lead foot. Okay, so this is 3 unipolar augmented leads, which give you 3 further angles to look at the heart. And then when you want to look at the left, when you want to look at the ventricles, you have 6 chest leads, which are placed in the precordium, and these are unipolar. So the 3 leads 1, 2, and 3 are bipolar, which means they have a positive and a negative. The augmented leads are unipolar. That means they only have a positive. The negative is the cardiac muscle itself. So AVR, AVL, AVF. And then you have 6 unipolar precordial leads. So how is the arrangement of these leads to give you, a horizontal? So let's look at the bipolar lead first. So bipolar and augmented leads, the bipolar and augmented, which is the first 6 ones that I mentioned, they look at the heart in a coronal section. What do you mean by a coronal section? A coronal section means a vertical section. Okay, this vertical section is called as a coronal section. So if you cut the heart open like this, the 6 leads are looking at the heart from all around. Do you understand that? So this is a coronal section, and the 3 bipolar and the 3 augmented leads, 1, 2, 3, AVL, AVF, AVR, look at the heart from around the heart in a coronal section. As compared to that, the chest leads actually look at the heart in a horizontal or a transverse section. So they cut across the heart transversely. Okay, so they cut across the heart in a horizontal section. So now let's look at the 3 leads and understand first the bipolar leads. Okay, is this clear so far?
Yes, sir.
So now the bipolar leads are, look here, lead 1, lead 2, and lead 3. If this is your heart in the middle, I told you already that for lead 2, there is a positive near the A on this side and a negative on this side. So this arrow, all activity, electrical activity, which is moving in the heart, this is the arrow of the lead 2. Okay. Lead 1 has a negative in the right arm and a positive in the left arm. So all activity is here. So lead 2 is looking, always you have to imagine the positive to be your eye. Imagine that the positive is your eye. And if you place your eye on the positive, then lead 1 is looking at the heart from this angle. Yeah? Lead 1 is looking at the heart from this angle. If you place your eye at the positive of lead 2, then lead 2 is looking at the heart from this angle. Okay? And lead 3 looks at the heart, because the positive is here, it looks at the heart from this angle, but slightly more to the front. Okay, so let me show you what happens. So positive electrodes are looking towards the negative electrode. Did you understand this concept? Positive electrodes are always looking at the negative electrodes. All deflections are based on view from the positive electrode. So whenever I showed you earlier that if the action potential is moving towards the positive, there will be a positive deflection. If it is moving away from the positive, it will be a negative deflection. Lead 1 looks at the heart from the left lateral position. Okay, left side and lateral position of the heart. Lead 2 looks at the heart from inferior but plus 60. Stay with me on this plus 60. I will explain it in a minute. And lead 3 looks at the heart from plus 120. Okay, so inferiorly but plus 120. So what do you mean by this plus 60 plus 120? So if you divide an axis for the heart, if 0 is this, and this is your horizontal axis, and if you count from here, if you go clockwise, the axis goes 0 to 180 this way. Okay, so 0, 10. So it is an angle that you're forming. So 0, 10, 20, 30, 40. So lead 2, the positive of the lead 2 lies at plus 60 angle of the axis. The lead 3 lies at plus 120. So lead 3 is always looking at the heart from this side. Lead 2 is always looking at the heart from this side. And lead 1 is always counted as 0. So lead 1 is looking at the heart from this side. Okay, so the left lateral is lead 1. The inferior is lead 2, but looking at plus 60. And the inferior, but more towards the right side, is lead 3. Again, looking at it, but from a plus 120 degrees. Did this make sense so far? Don't worry if you don't understand the axis just as yet. I'm going to cover it in more detail. Okay, so that's lead 1, lead 2, and lead 3. Okay, now this is just a little bit of extra information for you. You may know it, may not know it, it doesn't matter. Lead 2, there is something called as an Einthoven's law. Einthoven's law states that lead 2 complex is always equal to 1 plus 3. So whatever deflection is happening in 1, the net deflection of 1 plus the net deflection of 2 is always equal to net deflection, and 1 and 3 is always equal to net deflection of 2. So lead 2 is the most important one, and 2 is equal to net deflection of 1 and 3. I'll give you an example. So if in lead 1, the R has gone up 7 mm, okay, and the S has gone down minus 2 mm. So the net deflection is plus 5. 7 minus 2 is plus 5, okay? If lead 3, the R is 1, plus 1, the S, there was more negative deflection in lead 2. So S was minus 15. So the net deflection is minus 16. Sorry, this is not 15, 16. So the net deflection will be minus 15. So when you want to make calculate lead 2, actually lead 1 plus lead 3, 5 plus minus 10 will give you minus 5 plus minus 15 will give you minus 10. Don't worry about it if you don't understand. The concept that I'm trying to make to you is all leads, when they're coming from the 3 angles and direction, they always will end up being electrically equilateral. That is one concept. It doesn't matter the top part whether you understood or not. But if ever you want to identify if an ECG is of good quality, or is it actually representing the activity in the heart, has it been taken correctly, or have the leads been correctly put or not put, all you have to do is calculate lead 1, calculate lead 2, add the 2 together. If 1 and 3 are equal to 2, then it is a correct ECG. Sometimes, you may put the wrong lead, you may put plus here, minus here, you may make a mistake in how you put your positives and negatives. And if you've made a mistake, then the way to check it is to check for electrical equilateral triangle. The triangle has to be electrically equilateral, okay? This is just theory, you don't need to know this. The ECG machine calculates all this and automatically tells you whether the leads are proper or not proper, okay? Is it okay so far?
Yes, sir.
Yeah, are you understanding the basics?
Yes, sir.
Okay, so now let's look at augmented lead. I told you augmented leads have a negative in the center. That means the heart is the negative and it only has a positive. Okay, so AVR is on the right arm. The AVL is on the left arm and AVF is on the foot. Okay, and always it is the positive electrode which is looking towards the heart. Okay, so this is important to understand. This is AVR, this is AVL, and this is AVF. So each one of them will look at the heart in a different way. So if you're talking about the AVR, it is looking at the top of the heart. Put your eye where the positive is and look at the heart. So AVR is looking at the right side and the superior surface of the heart. AVR goes along the right side of the heart. Okay. If you talk about AVL, AVL goes left and lateral. Yeah, it's the positive is here, it's looking at the left and lateral. The AVF is here, it is the inferior surface, it is looking at the inferior border of the heart. So you will say, why do I need AVL, AVF, AVR? Why not just do with 1, 2, and 3? The thing is, if you understand the axis, I said 1 is at 0, that 2 is at plus 60. So AVF lies at 90. So it is giving you one more angle to look at the heart. Your lead 3 is lying at plus 150, so plus 120. So again, you're getting another angle. 3 is looking at it from here. AVF is looking at it from here. 2 is looking here. 1 is looking here. AVL is looking here. And then the AVF is looking from the top. So basically using these extra leads, you get more images. And so you are able to look at the heart all along. And really the reason why you have more leads down here is the electrical activity in the ventricles that is very important, because atrium can be picked up very well, but it is the ventricle that can be a problem to look at because it's thicker and has got more muscle. So you need more leads to look at the ventricle from down here rather than the atrium. Okay, does it make sense? So just if we look at this picture, and I just told you that 0 degrees was 1, plus lead 2 was at plus 60, lead 3 was at plus 90, AVF was at plus 90, lead 3 was at plus 120. AVR, if you calculate, is minus 150. This is minus 30 because this goes minus 0 to minus 180. So if I ask you which lead should I look for an inferior myocardial infarction, okay, now the concept is becoming clear. How to use this knowledge for clinical practice. So if I want to look for a heart attack or an MI which is affecting the inferior portion of the heart, I will look in lead 2, I will look in AVF, and I will look in lead 3. Do you understand that? This is the significance of the arrangement of the leads. So if I want to look at inferior MI, I will look at lead 2, I'll look at AVF and 3. They will all give me idea what is happening in the base of the heart. If I want to look at the left lateral side of the heart, if I want to look at MI happening on this side, I will use lead 1, which we've understood. I will use AVL, which will look at the left lateral. And then there are further chest leads, which are V5 and V6, which we'll talk about in a minute. Okay, so this is the way you understand how the leads, the orientation of the leads in a 360-degree axis gives you different angles of the heart, looking at it in a vertical plane. The key thing is this is all activity in a vertical plane. So here you are, this is the representation in a vertical plane. Always lead 2 is positive looking from down here. So this is positive, positive, and positive. And then the negatives are the Q and the S. Similarly, if you look at AVR, okay, which is looking from here, all the activity is reversed. Can you see that? The AVR is diametrically opposite of 2. It is coming from this side. So when lead 2 gives you a vertical deflection of the P, the AVR is giving you a negative P. The P is opposite because it's going away from that lead. So this is the understanding. So this is normal for AVR and this is normal for lead 2. So it is very, very important to understand what is the view that you look. So AVR is always negative activity. A lead 2 is always positive. Whatever is positive in lead 2 will be negative in lead in AVR. Same thing, lead 1 and lead 3 are opposite to each other. Okay, so look at this P here. You're seeing the P there, but here you're not seeing a very good P. You understand that? Here you're seeing a very good R, but look at here, the R is gone down here. So it is very important to understand that leads are opposite each other. Hence the electrical activity changes from lead to lead. Again, the same thing to represent. Look at lead 2. Always, always, always start with lead 2. So see this P, Q, R, S. S is not very prominent here. This is the ST segment. That is the T wave. Okay. Oh, sorry. Opposite. Because the R is looking from another angle, from the top. So all activity which was going towards lead 2 is now going away from AVR. So look at this. P is reverse. P is upright. You know, QRS is reverse. QRS is upright. T is reverse. T is upright. Same thing between 1 and 3. Okay, there 1 and AVL actually is more opposite to each other. And if you see AVL, the other thing to notice, look at AVL carefully now. Just look at AVL carefully. The one thing I want you to understand, look at the QRS in the AVL. Okay, the QRS in the AVL is what is called as equilateral, which means equal R and equal S. Can you see that? Equal R and equal S. Whenever there is an isolateral movement or isoelectric QRS, it means that the axis of movement is perpendicular to that. So really we know the heart action potential is moving from here to here. So when the heart action potential moves from the SA node through the bundle of His, the deflection of the QRS is equal R and equal S, because it's neither grossly positive nor grossly negative. Whereas here, it is highly positive because it's towards. Here it is highly negative because it is away. But look at VL. it is equilateral movement. And this is very, very, very important when you want to calculate the axis of the heart. I'll talk about axis deviation. So this equilateral movement of R and S becomes very important when you are trying to calculate what is the axis of movement of action potential in the heart. Is this clear?
Yes, sir.
Yeah, so far so good or no?
Yes, sir.
Okay, very good. Now let's look at another angle. Let's cut the heart horizontally across. Okay, first we were looking vertically. Let's look at the heart horizontally across. So if you want to chop the heart horizontally across, let's put one lead in the fourth intercostal space. So go to the angle of Louis. This is the second. Count down 2, 3, 4. Come to the fourth intercostal space. Go into the right side of your sternoclavicular margin and put one lead. That lead is called as V1. The same thing, you come to the opposite side, the left sternocostal margin in the fourth intercostal space. Put ECG lead there. It's a positive lead. That is called as V2. Forget V3 at the moment. Come in the fifth intercostal space and go in the mid-clavicular line. So draw a mid-clavicular line and put one lead there. That is called as V4. Between V4 and V3, come halfway and put V3. So V4 and V2, come halfway and put one lead, which is called as V3. Go in the anterior axillary line in the fifth intercostal space and put one lead, that is called as V5. And then put another lead in the sixth intercostal space in the mid axillary line, that is called as V6. So now you are covering the heart all around from in a horizontal axis. So this is how you will start looking at the heart now. You're chopping it across and you put V1, V2, V3, V4, V5, V6. In fact, if you want to look at the posterior side of the heart, you can also put 7, 8, and 9. The ECG machine will allow you. There is a setup where you can put 1 year, 1 year, and 1 year. And when you're looking for posterior infarcts rather than inferior infarcts, if you want to look at posterior infarcts, then you have to put leads 7, 8, and 9, and that will give you elements in a posterior infarct. Also, as I said, they are positive. They are all positive electrodes. There is no negative in the chest electrodes. Okay, they are all positive electrodes. They have a horizontal or a transverse plane. They are chopping the heart horizontally and looking at it. And predominantly, the chest leads always look at ventricular activity. We are not interested so much in atrial activity when we are looking at the V leads. The V leads always give you ventricular activity. You really want to use the V leads to look for ventricular activity. If you want to look for atrial activity, you look at 2 and AVR. They will give you good indication. So this is the horizontal chop. Can you see that? We are chopping it horizontally across. So the horizontal plane is what gives you the reading in a chest lead. That is the important thing to understand. Now, again, what areas of the heart are we looking when we are using V1 to V6 or V9? So if you are using V1 and V2, any changes in the septum are represented in V1 and V2. So if you want to look for septal infarcts, the most sensitive one is V1 and V2. If you want to look at the anterior and the apical area of the heart, then you go into V3 and V4. V3 and V4 shows you changes in the anterior and apical area of the heart. Remember, we are going across like this in a horizontal section. And if you want to look at anterolateral, so from the lateral side, then you look at V5 and V6. And if you want to look at posterior infarcts, then you put this additional leads. Can you see the 7, 8, and 9? You put it at the back next to the vertebral column there, and that will give you posterior infarcts. Okay, so the leads are very important to understand. V1 all the way to V6, and they are moving in a horizontal plane from an anteroseptal to an anterolateral view. And these are the ventricular regions that are represented by V1 to V6. And of course, I forgot about the posterior leads. Okay, so in a V lead, we are not so much fussed about the P wave. Can you see that? All of this, we're not fussed about the P wave. We are more fussed about the QRS and the T segment. Okay, and this is how the representation happens. If you follow this, you will understand. And then you come to this lateral thing and it becomes isoelectric because all the movement is towards V2. Okay, and see how the change is from more negative to more positive. Yeah, see that there's more negative V1, more negative, because this was moving away. The impulse was moving away. And then when it's coming back towards V2, the impulse is moving towards V5 and V6. So when it comes from there, so what is more negative in V1 is actually pretty positive in V5 and V6 because the impulse is moving towards the apex of the heart and the lateral border of the heart. And then V4, if you can see, is isoelectric, which means it is right in the middle where it has equal positive and equal negative deflection. Can you see that? This is normal. Okay, this is absolutely normal. And this is how tracings come out and they give you an indication. So anytime you see changes, this is the posterior infarct. I told you we lead 7, 8, and 9. This is to look for posterior areas of the heart. So now are you clear about the 12 leads? It's very, very important to understand how we are looking at the heart. First 6 are in the vertical section of the heart. The next 6 are in the horizontal section of the heart. And each of these leads together look at a different area of the heart. Hence, it helps you to diagnose various pathologies. Is it clear? So LA is left arm, RA is the right arm, LL is left leg. It's just we are making a triangle, okay? And that is the way we represent. And this is how you get a whole ECG. This is a normal ECG, lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 to V6 all the way. And the last thing in there is called as a rhythm strip. The rhythm strip is usually kept for lead 2. I told you lead 2 is the best one to look for both atrial and ventricular activity. And because everything is moving towards a positive in a straight line, lead 2 gives you the best understanding of a rhythm of the heart. So the base one is always rhythm. Have you understood this? Are you clear or no? Yes or no?
Yes, sir.
Okay. This first hour is the most important thing, okay? Everything else, it's easy to diagnose. Once you understand where is that activity moving towards, that is what you have to understand. So now there is a concept of cardiac axis. I told you a little bit earlier, but let me now clarify a bit more. So look at this. This axis, if this is the orientation of the heart, this is just a graphical representation. So they drew a line across like this. And they call lead 1, which is looking at it from this side, as 0 degrees. So if lead 1 is 0 degrees, then what is diametrically opposite is 180 degrees. So 0 to 180 moves in a clockwise fashion. So from a 0 plus 30 plus 60, which actually is where lead 2 is sitting, plus 90 where lead AVF is sitting, plus 120 where lead 3 is sitting, plus 150 we are not looking at, plus 180 we are not looking at. If you want, you can put more leads. But this is enough to give you a good picture of what's happening. And then if you go the other way, the anti-clockwise from the top, minus 30 is where AVL is sitting, plus minus 60, minus 90, minus 120. This area is left atrium. We're not so much interested in the left atrium because most of that activity is happening down here in the septum, and all blocks and everything get picked up in this area. So we are not really so much interested in this, but we've got one thing which is looking from the top, which is enough to give us an understanding from this area to this area, which is the AVR. And AVR sits at minus 150. Okay. So now let's look and understand what do you mean by axis. So this I've showed you already. So normal axis of the heart runs from minus 30 to plus 120, which is from AVL to lead 3. If the direction of the action potential, it lies within this axis, then it is called as a normal axis, okay? This means there is no problem with the structure of the heart. Everything is moving exactly as it was designed, and the net vector has to lie between from here to here. If the net vector lies from here to here, we usually call it as normal axis. We are not worried about it. So this is what is the net vector. Can you see that? So we are happy with this net vector. If it is moving between AVF and AVL, we are happy. It is actually moving in the right direction. Everything is okay. We have no problems. Suppose for whatever reason, the left ventricle becomes hypertrophic. Okay, it becomes thickened. Say there is increase in the mass of the left ventricle for some disease pathology, cardiomyopathy, some stenosis of the valves, whatever. We are not talking about pathology at the moment. But just imagine if this gets thickened. If this gets thickened, then what will happen is there is more electrical activity on the left side as compared to the right side. As a result of which this net vector will move more to the left, obviously, because more activity here. So the average of all the vectors will move that side. Can you see that? So this movement of the vector to the left side is called as left axis deviation. And if the opposite is, if there is right ventricular hypertrophy, for whatever reason, the right ventricle has become thickened, or the impulse is going more towards the right side because the left bundle branch has been blocked, then all the impulse is going this side. So the net activity will move this way. And purely on an ECG, by looking at the net activity, we can say whether the patient has right axis deviation or left axis deviation. And right axis and left axis deviation gives you a subtle clue as to, is there a left ventricular hypertrophy or right ventricular hypertrophy? Or is there any block in the conduction? Is the conduction going down preferentially to the right side rather than the left side? So this is normal. From AVF to -30 is the normal axis. The moment the axis moves beyond this, we call it as left axis deviation, and it moves this side, it's called as right axis deviation. Most of the axis deviation is within this zone, okay? But occasionally the axis deviation becomes minus 90 to -180. And that is extreme axis deviation. Extreme axis deviation is not very common at all. But you must be able to find out on an ECG if the axis is going completely the opposite side rather than towards lead 2. Okay, so you've understood now that if there is hypertrophy of the left ventricle, the axis will move this side, obviously, because more muscle that side, more positive activity going that side, so more will the deviation happen there. If you look, if right ventricle becomes hypertrophic, the axis will move to the right because more activity is to the right, so more deviation is to the right. Did you understand this concept? What is right axis deviation and what is left axis deviation? Did it make sense? I'm just going to come to ECG in a minute. Yes or no?
Yes, sir.
Yes, sir.
Yes,
Yeah,
sir.
everybody is clear? So
Yes, sir.
the axis deviation is no big deal. It only tells you, it gives you a clue on the ECG whether is it hypertrophy or not. You know, is there a bundle branch? Is the axis moving to the left or is it axis moving to the right? So let's look at the next ECG, okay? This is a normal ECG, okay? Now, let's look at the positive and negative deflections. I want you to understand the positive, and so I'm going to put this graph down here, okay? And I'm going to put positive. So look at lead 1 is positive deflection. We know lead 1 is looking from this side. Okay, lead 1 is looking at the heart from this side, and there is more positive deflection in this. So obviously the axis is pointing towards lead 1. Let's look at lead 2. Lead 2 is also positive. So yes, it is pointing towards lead 2. You agree or no? Because there is positive deflection, that means the action potential is moving either towards lead 1 or towards lead 2. Both of them are showing positive deflections, right? Have you understood or no? Stay with me, please.
Yes, sir.
So the axis is moving either towards lead 1 or towards lead 2. We don't have to be very fine about it. All we need to know is it's moving in the right direction. So we can take a net vector, and the net vector is moving in this angle. Okay? So that is lying in the green zone, which we are happy about. Now, another way to know it is isoelectric. So look at what is isoelectric. So look here, this is equal Q and equal S, equal R and equal S. When there is an equal R and an equal S, that means the axis is at 90 degrees to it, right? Because it is 90 degrees, so equal deflection top and bottom. So this is the axis of this ECG, because AVL, which is coming from here, is showing equal R and equal S. So obviously the axis is 90 degrees. Either it's going this way or it is going this way. But the axis is 90 degrees. So now look at AVR. We want to know, is it pointing towards 2 or is it pointing to... So we know it is pointing here because we've seen positive activity in 2. We've seen positive activity in 1. But also in AVR, you have to look AVR. See, AVR has got negative activity. So AVR, so it cannot possibly be going this way. So it is going this way. Can you understand? This is how you calculate the vectors. This is how you calculate the axis of an ECG. So now we know that 2 lies at plus 30. So the axis of this normal ECG is plus 30. Did you understand that?
Yes, sir.
Yes or no? Sorry,
Yes,
plus
sir.
60, not plus 30. Plus 60 because it's going towards 2. Yeah? So AVL was isoelectric. So the axis had to be 90 degrees to it. And because it was 90 degrees, we looked at AVR. The AVR is showing negative. So it cannot be going towards AVR. It just cannot be going towards AVR. So now we know it is going towards 2. And if it's going towards 2, it is plus 60. That is the axis of this ECG. Have you understood how to calculate the axis? It's very easy, but it gives you a great information about what's happening in the heart, okay? Whether there's thickening or not thickening of the heart. Now look at this next ECG. This is your axis, keep it here. Let's look at 1. 1 is positive, okay, good. So we know that the axis is going towards 1 for sure. Look at 2. 2 is more negative. Yeah, this is different from previous. In the previous one, 2 was positive. So obviously if 2 is negative, it cannot be coming this way. It's going somewhere this way. Yeah. Look at AVL. AVL is here. AVL is strongly positive. So we know that this axis is going somewhere this way because AVL is strongly positive. Yeah. So more important is to understand positive. Look at AVF. AVF is negative. AVF is here. So it is going this way. If it is negative, it's got to go away. So here, the axis is actually in between minus 30 and minus 90 because it's going towards the AVL, which is strongly positive. It is going away from lead 2. Yeah, because lead 2 is negative here. There's more negative than positive in lead 2. So obviously it is going away from lead 2. And this axis now is lying in a red zone. And the red zone that is lying in is called as left axis deviation. Did you understand how to calculate axis? So when you know that there is left axis deviation, probably the left ventricle is very thickened. Probably there is left ventricular hypertrophy. We don't know that, but at least it's giving you a clue of the diagnosis, what is going to happen in the heart. So the moment you see positive, negatives, wherever there is more positive, it means the axis pointing towards that area. Okay? Is it clear or no? Guys,
Yes,
give
sir.
me feedback. Otherwise, I will not know what I'm saying.
Yes, sir.
Yeah. Okay. Now let's look at this ECG. Okay. So let's look at this ECG. Beautiful. Lead 2. Look at lead 2. Okay. Let me bring up the axis chart. Just once. Okay. So let me bring up the axis graph. So look at lead 2. Lead 2 is isoelectric. Yeah. Isoelectric. That means the activity is going 90 degrees to this. Yeah. Lead 2 is isoelectric. So activity is going 90 degrees to this. Definitely. Lead 1 is more negative. Yeah. So probably the activity is going more this way. You understood that? So lead 2 is isoelectric. So it means it is 90 degrees to lead 2. Lead 1 is also negative. So it cannot be going this way 90 degrees. So it's probably going this way 90 degrees. So let's draw this. So this was the axis. Lead 2 is isoelectric. more equal positive negative. So it's isoelectric. Lead 1 is negative. So it cannot be possibly going this way, because if it was going this way, it would be positive. Lead 1 would become positive. AVL would become positive. Let's look at AVL. Where is AVL? Look, AVL is more. Sorry, where is I can't see. Here, AVL is more negative. This is AVL. AVL is more negative. So again, it cannot be going towards AVL. So obviously, what is happening is going away from AVL, away from lead 1. So this is going this way. Now the axis is lying in this zone. And we have said that this is normal axis of the heart. So the whole axis of the heart is moved away towards this. Sorry about that. The whole axis is moved this way. So this is called as a right axis deviation. So the reason why this axis deviation has happened is probably either the right ventricle has become hypertrophied, or there is a block on the left bundle branch. If there is a block in the left bundle, all the activity is going down the right bundle and predominantly stimulating the right heart before the left heart. And that is why the axis is moved away. So it gives you a clue as to what is the underlying pathology happening within the heart. Now let's look at another ECG, okay, just to look at axis. Now this is a very, very very complex ECGs. There's lots happening here. But the important thing that we have to look at is look at AVL. AVL is the one which is looking isoelectric. Okay, amongst all of this, there's a lot of activity. There's a lot of negative in 2, a lot of negative in 1. Can you see that? Negative in 1, negative in 2, negative in 3. So AVL is the one that's looking a little isoelectric. So activity is happening 90 degrees to AVL. Okay, so you draw this line. Now the question is we have to ask is it this way or is it that way? So axis can only be one way. It cannot be both ways. So 2 is unlikely because look at all the negative in 2. Okay, 1 is also unlikely because look at all the negative in 1. So lot of negative in 1, lot of negative in 2. Unlikely that the direction is this way. So the direction has got to be in the opposite direction. And the way to confirm is to look at AVR. When you look at AVR, look lot of positive activity in AVR. The moment you get a lot of positive activity in the AVR means that this direction is pointing towards AVR. This is not normal. This is not what happens in a normal heart. In a normal heart, all activity has to point towards this way. So there is definitely something grossly wrong with the heart. There's a lot of dissociation between the atrial and the ventricular activity. Something has gone grossly wrong. And so this is called as extreme axis deviation. You could call it extreme left axis deviation if it lied in this area, or extreme right axis deviation in this area. But it doesn't matter. It is extreme axis deviation. And that is the way you pick it up by looking at this graph. This graph is very important to understand activity in the myocardium. So the isoelectric lead method means you find the isoelectric lead, you find the positive lead, always draw a 90-degree axis to the QRS, pointing to the positive things. And then once you've drawn this 90 degrees, so in this, you find the isoelectric lead. This is the isoelectric lead. So look at AVL, isoelectric lead, 90 degrees, you draw a line. And then the moment you've drawn that line, then look for where there is more positive. And so 1 is more positive, 2 is more positive. So it probably is this one, not this one. And so that's your answer. This is how you calculate using isoelectric method for calculating the axis of an ECG. Okay, so this is another one you can, if you want, you can use it as an example to calculate. I won't spend too much time on this. Look, the isoelectric one is lead 2. So everything is along a horizontal axis of lead 2. AVL is strongly positive. So AVL comes from this side, we know that. So this is a left axis deviation. AVL positive, isoelectric lead 2, lead 1 is positive. Everything is going towards this side, but more towards the AVL side. So it is left axis deviation. This is how you calculate it on an ECG. Did it make sense? Yes or no?
Yes, sir.
Is it absolutely clear or no?
Yes,
Okay.
sir.
So this is normal axis. Yeah, positive here, negative here. Okay, look at that opposite. So 2 is positive, VR, the right side is negative. Go down, This is slightly deviating this side, okay? This is left side, okay? So this is left normal cardiac axis, this is right cardiac axis, right axis deviation, and this is left axis deviation. Look at left axis, grossly gone that side. Yeah, so this has become more negative. Yeah, okay. Thank you. Did you understand that? So what happens in a right axis deviation? It may be normal, it may show right ventricular hypertrophy. A lateral MI with some infarcts may show that. Dextrocardia can also happen. Remember always dextrocardia as a diagnosis. So whenever you do any ECG, when you look at axis, you always have a differential diagnosis. Don't just give one diagnosis. Always try to understand a differential diagnosis and then use more of the information to cut down on the diagnosis. Once you use more of the information, then various diagnoses will get eliminated from the ECG. So in a left axis deviation, it could be any of these, okay? And it doesn't matter which one of these is. The analysis further of the ECG will help you to pick up each one of these and give you an answer as to what is happening. Okay, so this is a normal 12 lead ECG, okay? All right, so far so good. Is it clear? Do you want me to continue or do you want me to take a break or what do you want to do? Continue another day?
Continue, sir. Continue.
Continue, sir.
Is it making sense? Are you bored so far?
No, no, sir.
Okay, so now let's get a few normal things in, okay? So we've looked at axis, we've looked at understanding what is positive deflection, we've looked at what is negative deflection. Now let's look at some normal things. So PR interval normally is 0.12 to 0.20. Stay with me about these small scale squares. I've not yet spoken about it, so we'll talk about it. Normal QRS is 0.8 to 0.12 seconds. This is normal facts, which I cannot change. You just have to remember these. QT interval is 0.3 to 0.43. The PR interval should really be referred to as PQ interval rather than PR, because it really is the Q that starts the QRS complex. But terminology is used as a PR and we just continue using it. And so this is the understanding of the PR interval, okay? So this is really PQ interval. So these are normal figures, just remember these. 0.12 to 0.20. Again, this will become clear once I show you the graph. Okay, and this is QRS width is normal is 0.08 to 0.12. We look for 0.12. Forget the squares, I'm not talking about it at the moment. I've not yet spoken about the rate. And the QT interval, the normal QT interval is 0.35. QT is from year to year, okay? So QT, this is the QT interval. Normal is 0.35 to 0.43. Okay, again, look on an ECG, when you start calculating things, you have small squares and large squares, okay? So you have to use the small squares and you have to use the large squares. Again, I'll show you in a minute. So if you look carefully on a large square, this is normal. 0.12 second is normal. And this is what a prolonged QRS will look like. Can you see that? This is a prolonged QRS. It's more than 200 milliseconds. And this will become clear when I talk about the rate. So first, before you talk about anything else, you have to talk about calibration of an ECG. An ECG should always be calibrated in such a way that 1 millivolt of change in the complex, in the electrical complex, must move the stylus 1 centimeter. So it must go 1 centimeter up or 1 centimeter down. So 1 millivolt change in an ECG should move the stylus 1 centimeter, which is 2 large squares. 1 large square is half a centimeter. So if you do an ECG and your machine is not properly calibrated, then if your calibration is not wrong, all the readings of the QRS will be wrong. And you'll be completely disappointed and you will make wrong diagnosis. So before you read any ECG, you have to make sure that the calibration of the machine is right. And any ECG always will show you the calibration at the start of the graph. And this is how the calibration looks like. This square wave is called as calibration wave. And so if it is going only half a centimeter, that's no good. If it is going too high, that's not good. It's got to go properly, 1 centimeter. That is a proper calibration of an ECG, okay? So this is, the calibration should always be 1 millivolt is equal to 1 centimeter deflection. So this is an under-calibrated. If you look at this, this is an under-calibrated ECG. Whenever the ECG is under-calibrated, your deflections are less, and so the all complexes become squeezed up and they look abnormal, and you might end up making a wrong diagnosis purely because you did not understand the calibration of the ECG. So very, very important to understand what is a calibration of the ECG. So that's the first point whenever you look at an ECG, always calibration. Now, when you have an ECG in your hand, a 12-lead ECG, the first thing you look at is calibration. The second thing you look at is the rhythm. So when you start interpreting an ECG, you have to start with looking at the rhythm strip, which is at the bottom of the ECG. So the lead 2 will always be given to you as an extra reading to give you the rhythm of an ECG. So rhythm has to be calculated before the rate, because rate is calculated on the number of large squares between two R's. And if the rhythm is not correct, then you will end up making a mistake in calculating the rate. So always start with the rhythm, not the rate. So you start with the rhythm, understand whether each P is followed by a QRS. Is the PR interval okay? One PQRST is followed by a same type of PQRST or not. That is called as a rhythm. So you have to look at multiple QRS complexes to understand the rhythm of an ECG. The next thing you look at is the rate of an ECG. Then you look at conduction intervals, and this is the PR, the QT, things like that. You have to make sure that all the conduction is happening fine. The next thing you look at is the axis. I showed you how to calculate the axis. So look at the deviation upwards, deviation downwards. If it's an equilateral deviation, then all conduction is happening at 90 degrees. And you calculate the axis of the ECG. Then you look at the QRS. You describe the QRS to yourself. Is it a normal upward, downward stroke? Is there a notch in the QRS? Is there an elevation of the ST segment? Things like that. So you have to next describe the ST segment, and more importantly, you have to also look at the T waves. So the whole ECG has to be read step by step. Do not try to diagnose things purely by looking at one finding. Then you will miss a lot of other findings. So whenever you're practicing and teaching yourself ECG, learn to look at an ECG in this way: rhythm, rate, conduction, axis, QRS, ST, and T waves. Okay, so I'm going to repeat that: rhythm, rate, conduction, P wave, PR interval, if it is sinus rhythm or not. Look at the cardiac axis, understand if the cardiac axis is okay or not. Go on to look at the QRS complex, look at the duration of the QRS complex, look at the height of the R wave and S wave. Look for the presence of Q waves, because sometimes Q waves are pathological. Okay, in some instances, if Q wave is present, it might be pathological, and I'll tell you about that later. Look at ST segment, look at T waves, and that is how you calculate a whole ECG. So let's now go and understand the chart itself. Okay, so let's look at the rate. How do you calculate the rate? Now, there are 3 different ways to calculate the rate. But before you calculate the rate, you must know that an ECG, when it moves in the machine, it can move at 3 speeds. The normal speed is 25 millimeters per second. When the paper moves in a machine at 25 millimeters per second, you are moving 300 large squares in 1 minute. Okay, that's the rate of movement. So 25 millimeters per second means 300 large squares are moving in 1 second. All you have to do is you got to count the number of large squares between 2 R waves. The moment you count the number of large squares between 2 R waves, you use 300 and you divide it by the number of large squares. The moment you do that, you actually get the heart rate of the patient per minute. So purely by looking at a snapshot of an ECG, you can calculate what is happening in the heart in the heart over 1 minute. So just by looking at a few seconds, you are able to calculate what is happening over a whole minute. So 25 millimeters per second, again, each small square Each small square on an ECG represents 0.04 second. Okay, this is just normal facts. If you calculate 25 millimeters per second and you divide it, each small square actually represents 0.04 seconds. Each large square represents 0.2 seconds. Okay, again, this is direct calculation because 5 small squares make a large square. So you just divide 4 by 5 and you get 0.2. 5 large squares represent 1 second. Okay, 5 large squares represent 1 second. And the reason you need to know this is because you want to calculate the heart rate per minute. So just by looking at a few seconds of an ECG, you will be able to calculate the heart rate per minute. So moment you come here, look at this ECG. Let's see, first the rhythm is normal. If the rhythm is normal, then we are happy to use R2R technique. If the rhythm is abnormal, then we have to use a longer strip to calculate the heart rate. So let's look at here. The rhythm looks to be normal. PQRST, PQRST, I'm happy, PQRST. Everything is looking the same. It's all coming in one way. Now let me look at 2 Rs. So here is 1 R, here is 1 R. I'm going to calculate the large squares. I know each large square is 0.2 seconds. So 1, 2, 3, 4, 5. So in 1 second, I have represented, I got 5 large squares. Now, if this paper is moving 300 millimeters in 1 minute, then 300 divided by 5 will give me my heart rate. Okay, so that's the way you calculate. 300 divided by 5. 1, 2, 3, 4, 5. 300 divided by 5, which is 60. So this is how you calculate the heart rate based on a normal rhythm. The key here is normal rhythm. What to do if the rhythm is not normal? Then there is another method. Okay, this is just the same one. I'm just repeating the same. So 300, this is 1, 2, 3, 4, 5, 300 divided 1, 2, 3, 4. So 300 divided by 4. In this, it is 75 per minute. That is the normal rate of this patient. So there is a calculation for that. If it is 1 large square, then it's 300 beats per minute. And if it is 6 large squares, then it is 50 beats per minute. So if you know this, this is very standard. If you know this, normal heart rate normally varies between 50 and 100. So most of them will be either 4 or 5 large squares between there, anywhere between 3 to 5 large squares, and that will give you the calculation straight away. What do you do if the rhythm is not normal? If the rhythm is not normal, then you look at a longer strip. Look at the rhythm strip and look for 10 seconds, okay? If you look at 10 seconds, then you calculate the number of R waves in 10 seconds. And if you calculate the number of R waves in 10 seconds, if you multiply that by 60, that will give you the rate of heart rate of the patient. Because we have said that the ECG is moving in the machine at 25 millimeters per second. So this is the calculation. So look at this one, okay? So this is a 10-second strip. A 10-second strip, I'm going to calculate R. So I'm calculating 1, 2, 3, 4, 5, 6, 7, 8, 9. I know there are 9 R waves in a 10-second strip. So if I go by that calculation, then I will multiply 9 by 10, 9 by 6, and that will be 54 beats per minute. Okay, that's one way. The other way we said is calculate the number of R's. 1, 2, 3, 4, 5. Okay, so 300 by 5 will give you 55.6, whatever, 56 beats per minute. So this is not an accurate thing. It just gives you an approximate idea. So it doesn't mean 76 or 70. It's just, 60, 70, 100, 150. Usually it's a broad figure to give you an idea. Have you got tachycardia or have you got bradycardia? That's all you want to find out. So really that's the way. And if it's more difficult and it's a larger complex block, then you can actually use the small squares. And the way the calculation for small squares is, if you calculate the small squares between 2 R waves, you use 1500, because 1500 small squares will pass in 1 minute when that ECG is going at 25 mm per second. So you calculate 1500, divide by the number of small squares, and the number comes to the same. Okay, so these are the 3 methods of calculating. Sometimes you may also use a 6-second rhythm strip. If you don't have a 10-second rhythm strip, if you've got a 6-second rhythm strip, then instead of in a 10-second, you multiply by 6. In a 6-second, you multiply by 10 because you want to come to 1 minute. What you want is 1 minute. So either way, you use a 10. If you use a 10-second strip, you multiply by 6. If you use a 6-second strip, then you multiply by 10. So this is a 6-second rhythm strip. Very often in an exam, you might be given only a 6-second rhythm strip. Or when they do a mobile ECG, when they are out in the field, they might be able to only give you a 6-second strip. And a 6-second strip, you calculate the number of hours. So here you are, and you just multiply that by 10. So here you are 1, 2, 3, 4, 5, 6, 7. So 7 R waves in this. You multiply by 10 and the rate is 70. Okay. Have you understood this rate? There are 3 or 4 ways to calculate. Is it clear or not clear, guys? It is the easy part of the ECG, but most people are not able to use this. They are unfortunately struggle to calculate the rate.
Yes, sir.
Have you understood this? Yes or no?
Yes,
And
sir.
have you
clear, sir.
understood where you use 6 seconds, where you use 10 seconds, where? So rhythm is very important. You must understand the rhythm. If the rhythm is normal, it doesn't matter which one you're calculating. But if the rhythm is abnormal, then you have to use a 6 or a 10-second strip to calculate. So look for number of hours. Okay. All right. Sometimes important, like I told you, you must make sure that the ECG is moving at the right speed. Sometimes by mistake, if somebody's changed the column, it might be 50 millimeters per second. Okay, the rate may go faster. The machine has the capability. And if the rate goes faster, everything looks crazy. And you might end up making a mistake by calling it a long QRS or a long QT. You know, this is looking really long. Remember, this is double the speed. So it has gone wider, much wider. And in fact, this ECG will really go over 2 pages so much that you can't even get V1 to V6 on the same page. So always remember, look at the calibration. Never forget to look at the calibration. You will end up making a huge mistake by diagnosing this as a long QT interval, that there is some block going on in this patient because the QT interval is so long by using the square. So always, always, always. See, the 50 millimeter strip has gone on to the next screen. Okay, so very, very important to know the rate. 25 millimeters per second is the one that you must use. Sometimes in the exam, they will throw in a 50 millimeter per second. And unfortunately, you will end up calling it a prolonged PR interval or a prolonged QT interval. And all you needed to do was to look at the calibration and realize that they're fooling you. It is a normal ECG, but a 50 millimeter per second. And the same ECG, if you slow it down at 12.5 millimeter, look, everything is coming squeezed up. Everything is really squeezed up, and the P waves and R waves are looking really peaked up. And they're peaked because they're squeezed together. So it looks really worse, much worse. So the QRS is coming together. It shows as if there's a slower heart rate. You know, all the T waves are spiky. The Q waves have gone all over the place. So very important to understand. Look at the calibration. The calibration is all wrong. So if this calibration is not 1 millimeter equal to 1 volt, millivolt, this is not an ECG you want to interpret. Or if you want to interpret, you have to take that into the account when you do that, when you look at the ECG. Okay, now let's look at some normal variations of ECG. Let's look at what happens when you do not get an ECG in a good patient, when you do not get a proper tracing. Okay, so look at normal variants of ECG. So this patient, look at this ECG, it's all squiggly, all over the place. How the hell do you read this ECG? How do I know which is a P wave, which is a QRS, which is a T wave? This is completely not a good one. And the reason why you're getting all these squeaky things is because the patient is not relaxed. Do you know what's happening here? The skeletal muscle of that patient is interfering in the pacing spikes of the cardiac muscle. That's what's happening. So these squiggles that you're getting is because the patient's skeletal muscles are not relaxed. So for you to get only the heart tracing, you do not want the skeletal muscle to contract. It's very important to understand this. You do not want the skeletal muscle to contract. So it is absolutely important that the patient must lie back and relax. If he does not relax, the skeletal muscle twitches. disrupt the cardiac muscle, and the action potential that is being picked up by the ECG is from the skeletal muscle, not from the cardiac muscle. So this is not a good ECG. Do not interpret this ECG. Only answer when you're given this ECG in the exam is, this patient is not relaxed. Okay. All right. Let's look at it. Look at it. Shivering. This patient is cold and he's shivering. So the skeletal muscle spikes are so high that they are equal to cardiac muscle spikes. Look at all of this. So this is an ECG. This is the previous one where he's not relaxed. Small twitches happening and the patient is showing it on the ECG. This is shivering. He's actually got shivering and the ECG is showing the trace. And this ECG cannot be interpreted. These spikes are exaggerated when the patient is not relaxed, and because the skeletal muscle is contracting, it ultimately obliterates the cardiac spikes in 1, 2, and 3. Look at this. 1, 2, and 3 are the first ones which pick up this, because 1, 2, and 3 are bipolar leads. So they have a positive and a negative. The V1, V6 is not that much affected because they are all positive. These are all positive leads. And the negative is on the heart. So they're still picking up activity of the heart and they're pretty close to the heart. Whereas 1, 2, and 3 is right hand, and left leg. So they're very far away. So they pick up all the electrical activity of the skeletal muscle. And this is the kind of ECG that you get when a patient is shivering. So very, very important to understand when the patient is shivering. Again, this is a bizarre ECG. Look at this rhythm strip. This rhythm strip is absolutely nonsensical. What the hell is happening? Either this patient has got some weird, conduction defect, or he's got God knows what the hell. But this is not right. Something is not right. So what has happened is the electrical contact of the lead is not correct. So when you get an ECG like this, the first thing before you make a diagnosis, check the electrical contact. One of the leads has become loose, or there was sweat and the lead did not stick properly, or there was the gel was not applied and it got stuck directly to the, because the gel is important. The gel allows conduction of electrical impulse without altering the rhythm, without altering the frequency of the electrical fluctuation. So if you look at an ECG lead, you will see in the middle of the ECG lead, there is always a little bit of gel. It comes pre-stuck within there. But if the patient is sweating or you applied betadine and you apply the ECG on it, particularly in surgical patients, once you apply the ECG lead and you paint and drape the part, if betadine sneaks between the ECG lead, then you'll get this sort of tracing. And this is not good in an operative patient, because really, if the patient gets an MI while you're operating, you will never make out, because look at the ST segment in lead 2, it's all over the place. So very important to check out that the electrical contact of the ECG is normal, and always rhythm strip is the one that gives you a pretty good idea. And look at this one here. There is a very thick baseline. How the hell do you know what the hell is happening? You know, you cannot interpret this ECG. And this ECG has got so much high spikes because there is electrical interference. Either his phone is in his pocket and the phone has rung, or in an operative patient, you have used a diathermy. When you use a diathermy, the electrical circuit which the diathermy establishes will give you this wrong reading. And so all of this is not normal. This is not good. This is an improper ECG, and you should not interpret this ECG. You have to know that this is not a normal ECG. So this is what a normal ECG should look like, and this is how you should interpret an ECG. You have to go through the rhythm of the patient, calculate the rate by the large squares between the thing, look at the PR interval, and not just one, but you have to look at a sequence of PR. So go through the sequence, look at the PR interval, make sure that the PR interval is all okay. Again, make sure the PR interval is all okay. Look at the QRX complex, make sure the duration of the QRX complex is not more than 120 milliseconds. Calculate the axis of this ECG by looking at lead 1, looking at lead 2. All of this is positive. Lead 3 is also positive. So most of it is coming towards the right side. Look at T waves, it looks normal. That is also normal. So essentially, this is a normal ECG. Okay. So did you understand this concept so far? So good. Now we are, I don't think we will finish this topic in one lecture, because all the abnormal ECGs have to come. But let's look at sinus rhythm, okay? the sinus rhythm. What is a sinus rhythm? Sinus rhythm is very simple. One, there should be a P wave. Okay. The P wave should always be rounded. We don't want tall P waves. We don't want peak T waves. We don't want triangular P waves. Atrial depolarization is a simple, nice, rounded P wave. Each P wave should be the same shape. So you must look at multiple P waves and you should make sure that all the P waves are the same shape. All P waves should be followed by QRS complex. Very important. All P waves should be followed by QRS complex. The PR interval should be 3 to 5 small squares. And it should be constant between every beat. You have to keep looking at the beat, and the QRS interval should be constant, and the rhythm should be regular. Okay? Very important that the rhythm should be regular. Okay? And most important is we have understood that lead 2 is here. So the P wave should always be upright in the lead 2. Okay, there should be an upward deflection. And we know that the AVR is here. So the P wave should be inverted in an AVR. These are the two things to understand in a sinus rhythm. If the P wave is inverted in a lead 2, something is wrong. So this is a normal sinus rhythm. Look at that, P wave is upright. And this is a 12 lead ECG showing you the same thing. It's a nice upright. Look at lead 2 upright. Look at lead AVR, P wave is upside down. Can you see that? So this is going away from the heart. This is going away from the positive electrode. This is going towards the positive electrode. Look at multiple beats. It's all fine. The PR interval is about 3. The PR interval is 2 to 3 small squares. So PR interval is fine. So this is a normal sinus rhythm. Okay. Whenever you get abnormalities of the rhythm, you can get 2 abnormalities. The abnormality can arise from above this junction, or it can arise from below this junction. And the abnormality can arise because the focus is somewhere else. Can you see these? These stars are the focus. So if these stars kick off their own action potential, then you will get what is called as a supraventricular arrhythmia. Okay, supraventricular arrhythmia, above the ring of the ventricle. So this is supraventricular arrhythmia. And when the focus is below the ring of the ventricle, it is called as infraventricular arrhythmia. Okay, so look at this, infraventricular arrhythmia. I think we'll just finish the rhythm and then we'll have to stop because it's getting to be too long. So this is a strip that I've given you. This is a strip in front of you. You have to look at the strip. You have to look at the rate, rhythm, RR interval, P waves, P to QRS, and QRS. So let me just analyze this for you. Okay, so look at this things. Let's start calculating the rate. So the rate is 2 large squares. Yeah, 2 large squares, which is about 150 beats per minute. Again, 2 large squares. And if you want, you can use the rhythm strip for 10 seconds and calculate 1, 2, 3, 4, 5, and it will come to around 150 beats. This is a fast rate. Something is not right. But the important thing is, looks regular. Okay, there is PQRS, PQRS, PQRS. The P is not very well seen, to be honest, because the rate is so fast that the P is not being picked up. But the QRST looks to be regular. The distance between this is all regular. Okay, so this is a regular thing. P wave is not seen very well. Neither here you can see the P wave very well, nor in here you can see the P wave very well. Because this might be T rather than the P wave. It's so fast that the T and the P, there is no time between the repolarization and depolarization. So all the ventricular activity is being represented, but the atrial activity is not picked up. So the P is either difficult to tell or it is too narrow. Okay, something is not right. But the QRS looks normal. Okay, QRS is okay. This is all right. QRS is not prolonged, not 0.12 seconds. That's all right. So this is probably something happening to the P wave. The QRS is not a problem. The ventricle is not a problem here. There is a problem supraventricular. That means there's a problem in the atrial structure somewhere. Now there can be only 3 things which cause a supraventricular. Either it can be sinus tachycardia, or it can be a supraventricular tachycardia, or it could be atrial fibrillation. Okay, this is the way you analyze an ECG. So one of the 3 things are possible. So what will I do in this? How do I diagnose what is happening in this patient? What I will do is when I have a patient in front of me with this ECG, I'll actually give him vagal stimulation. I'll put my hand on the neck and I'll stimulate the carotid. the moment if you stimulate the carotid and the heart rate comes down, then you are dealing with SVT. Okay? If the heart rate comes down, you're dealing with SVT. If it doesn't come down, then it is either sinus tachycardia or AF. But it is not AF because the rhythm is regular. So it is either sinus tachycardia or SVT. AF is not possible because the rhythm is regular. AF gives you an irregular rhythm. So the moment you do vagal stimulation, if it comes down, then you know you're dealing with SVT rather than sinus tachycardia. The treatment of sinus tachycardia is fluid. Sinus tachycardia is because dehydration or the patient is becoming hypovolemic. Whereas SVT is something firing in the atria. So you start with vagal stimulation or carotid stimulation. The next thing you do is give him adenosine, 369 milligrams. As you give adenosine, if the heart rate drops, then you know that you're dealing with SVT. So this ECG, with using clinical information, you actually are able to eliminate disease and reach a diagnosis by using certain maneuvers. So this is how you analyze an ECG. It's never just a snapshot. It's always, a bigger picture. You have to look at the whole picture and analyze. So this is the real analysis of that previous SVC. So we have sat down with the patient and done a complete analysis and worked out what is the problem. So look at this ECG. Okay, this is the next ECG. So far so good. Have you understood or no? SVT. Hello.
Yes, sir.
Am I going too fast?
No, sir.
So now look at this ECG, okay? So look at this ECG and try to calculate the heart rate. So 1, 2, 3, 4, 5, 6. Around 6, it's quite low. So if you work it out, it comes to 66 beats per minute. If you take a 10-second strip, it is around 11 R waves in 10 seconds. So it is a 66 is the heart rate because you multiply it by 6. And look at the atrial things. Okay, so look at QRS is okay, QRS is okay, QRS is okay. But there's something, what the hell is happening here? Can you see this? Something is not right here. This is T somewhere here. This is T, but this is not right. Something is not right here. The P activity is not right. There is something happening in the atria, which is different. The QRS looks okay. There's no problem with the QRS. So there is definitely an irregular rhythm. Again, look here, this distance, 1, 2, 3. Here is 1, 2, 3, 4, 5, 6. So 6 here, 3 here. So this is definitely an irregular rhythm. Yeah. So for this, you will use a 12 strip and count the number of R waves and calculate the heart rate. You cannot use just these squares to calculate the heart rate because here there are only 3 boxes, here there are 6 boxes. But definitely there's an irregular rhythm. Definitely the problem is at the P wave. And we know that the P wave represents the atrium rather than the ventricle. So maybe we are dealing with atrial fibrillation. There is no P wave. And if you look carefully in 1 and in 2 as well, there are these are called as fibrillatory waves. So this is classical diagnosis that we are actually dealing with atrial fibrillation rather than atrial flutter. I'll show you flutter in a minute, okay? So this is atrial fibrillation, disturbance of rhythm with no disturbance in QRS complex. There is no problem with the conduction across the AV node and the bundle of His, and there is no problem with depolarization of the ventricle. The problem is excessive depolarization of the left atrium, and that is why we call this as atrial fibrillation. Okay? All right, so this is how you start diagnosing things. The easy guide to remember is always look at the rhythm and the rate. 60 to 100 is a normal rate. If it is going between 100 to 150, then it's sinus tachycardia. If it is 150 to 250, then it is SVT, more likely to be SVT. Supraventricular tachycardia, which is different from sinus tachycardia. If it is at 250 to 350, it's probably a flutter, which could be an atrial or a ventricular flutter. And if it is more than 350 to 450, it could be an atrial fibrillation or it could be a ventricular fibrillation. Again, here we are talking about the atrial beats, okay? So this is not the whole heart rate of the patient. We're talking about the atrial beats or the ventricular beats. The QRS in the last patient was normal. but the atrium was going at about 150 to 200 beats per minute. So always look, the P will have a separate rate and the QRS will have a separate rate. So you have to identify that. Okay, let's look at the next one. All right, now here is the CCG. I can't see a P wave in the CCG. Look at P wave. I can't see P waves here. The rhythm strip is missing for some reason, but I can't see the P waves here. Can you see the P waves? No. Okay. There is an irregular baseline. This is going up and down. Can you see that? This ECG is going up and down. Not happy with this. The QRS is also irregular. Okay, there's a varying rate. Somewhere it is 75, somewhere it's gone 90. See, even the QRS is changing the rate. Shape is normal though, and slightly narrow in the V1 to V6. The T wave appears to be normal. Look at T waves, that's okay. Look at T wave here. The T wave is not so good here, but here the T wave is okay. So this is again atrial fibrillation. So this is not an issue of the ventricle, but it is more an issue of the atrium because P wave is not seen. And so this is atrial fibrillation. This is a classical picture of atrial fibrillation, but I would have been happy if we had a rhythm strip. Sometimes they don't show you a rhythm strip and that becomes a problem, okay? So let's look at this one. Are you understanding this or no, guys, or am I going too fast?
Yes, sir.
Hello?
Understanding.
Understanding so far so good?
Yes,
Okay.
sir. Yes, yes.
Okay. Let's look at this strip, okay? If you calculate the rate is 150 beats per minute. Okay, you can use the 10-second method or you can use the RR interval, but better to use the 10-second method and calculate the number of Rs and divide it either by 10 if you're using 6 seconds and divide it by 6 if you're using 10 seconds. And this calculation will come to 150. It's a regular rhythm because look, QRS seems to be okay. Yeah, QRS. The gap between two Rs looks okay. Throughout the strip, the gap between the two Rs is okay. Yeah. The problem is P wave. I cannot see whether what is happening to the P wave here. Whether is it intermingling with the T segment or is it a sharp peaked T wave? It's very difficult to say here. So definitely there's a problem with the P wave. See here again, the P wave here doesn't look normal. There is definitely, it's a sharp P wave and a notch. Can you see this? This P wave, which is high peak and a notch. If you look here carefully, high peak and a notch, this P wave is called a sawtooth. This represents the saw. If you cut a wood, if you look at the blades of the wood, this P wave represents the sawtooth. Okay, it is same everywhere. You can see that this is a sawtooth P wave in lead 2. This is a sawtooth P wave, and whenever you get a sawtooth P wave, there is only one diagnosis, and that is atrial flutter. Always a sawtooth P wave has got only one diagnosis, atrial flutter. So let me show you a little more carefully. See this. Triangular sharp P wave, and multiple P waves between one QRS. So the QRS is at a different speed and the P wave is running at a different speed. Okay, so this is a sawtooth, and sawtooth typically appears in 2 AVR and V1, and this is called as F wave. This sharp P wave is called as an F wave. Somebody's microphone is on, guys. Just switch it on. Vivek, Vikas, just switch whoever's microphone is on. We are almost finished. In another few minutes, I'll stop. Okay, just bear with me for a few minutes. So this sharp P wave is called a sawtooth. And this is usually seen in 2 and AVR. We said that for P wave, we look in 2 and AVR because that is the line of the atrial axis. And again, the ratio is not right. So, this has got three P waves for 1 QRS. So if the block can be 1:1, 2:1, 3:1, depending on one. Commonly, it is 2:1. So 2 P waves extra for every QRS. 2 P waves extra for every QRS. And that is called as atrial flutter. Okay. Again, the same thing. See the sharp P wave. Okay. See the 2 extra P waves in there, 1 and 2 extra P waves. So this is a sawtooth P wave, if you calculate the rate, is 300 beats per minute, and 4 P waves for 1 QRS. Yeah. So 2 extra. So 1, 2, 3, and 4. This is also within the T. So this is also being calculated as a P wave. So this is a very, very classical case of atrial flutter. So ventricular beat is going at 300. Atrial beat is going, atrial beat is going at 300. Ventricular beat is going at 75. So that's a atrial flutter. Again, same thing, sawtooth, but a slower rate. P wave is 250 beats. There are 2 P waves for 1 QRS, and this is called as 2:1 block. The previous one was 4:1 block. You can get 3:1 block. You can get, if it goes faster, you can get 4:1. But the commonest atrial flutter you get is 2 P waves for 1 QRS. And 2:1 means 2 P waves are generated, but only one is going across the bundle of his to depolarize the ventricle. That is what you mean by 2:1. That 2 atrial depolarizations are being generated, but only one is transmitting across the AV node onto the ventricle. And so this is called as 2:1 block. Okay. All right. Just the last bit about rhythm. Is it okay, guys? Are you okay for me to finish rhythm, or do you want me to stop now?
No, sir. Yeah, okay, sir.
Okay.
Yeah, just let me finish rhythm, because then I can't start halfway through next time. Okay, now look at this one. This is quite good. So look at the first one. Okay, this is okay. P, QRS, T. Happy with this. P, QRS, T. No problems with this. But what the hell has happened here? What is this? Okay, so after one sinus rhythm, the SA failed to depolarize. The SA node did not depolarize any further. Okay. And then after a delay, an abnormal P wave is seen. See this abnormal P wave. This is not normal. It should have been up. So something is wrong here. The excitation, this QRS is coming from somewhere else. So something else is exciting the thing. But this P wave is not doing very well at all. So abnormal P wave followed by a normal QRS. Okay. This is called, and then it returns to sinus, and it returns to sinus. So here it has returned to sinus and again become abnormal. This is called a sinus arrhythmia or atrial escape. This is very classical. Atrial escape comes in the exam. So look at this: normal PQRS, abnormal P, but normal QRST. Yeah. Returning to sinus, but slightly arrhythmic. Again going back. This is called as atrial escape. This P is coming from here. A separate lesion is stimulating there, and this is going down here rather than SA node to AV node. This is called as atrial escape. Another focus is coming from the atrium that is stimulating. Let's look at this. After 3 Ps, after 3, there is one abnormal. Okay. So after 3 sinus, the SA node fails to discharge. There is no atrial or nodal escape seen. After a pause, a single but wide QRS. This is blank. Nothing has happened here. And then one wide QRS with an abnormal T wave. Look, the T wave is abnormal here as well. So this is a ventricular focus, which is controlling the heart for 1 beat. Can you see that this is not controlled from the atrium? This is ventricle throwing a separate beat by itself. Normal PQRS, but one is abnormal and then normal PQRS. So here is the focus. This is a ventricular ectopic. Okay, this is ventricular escape rhythm. So normal, heart is beating normally. Then this fellow suddenly decided to throw 1 beat inside and give you this abnormal QRS. And then heart has again gone back to being normal. So this is called as a ventricular escape because of an abnormal focus on the ventricle. Okay, now look at this one. This is important. Normal, normal, but what the hell is happening here? And again, normal. Okay, so something has happened after 2 sinus beats. The heart rate suddenly went up to 200. The QRS became broad, and the T wave is difficult to find. You can't find the T wave on this. Where is the T wave? It's all QRS. And then it returned to normal sinus rhythm. That is called as ventricular tachycardia. Okay, because this is QRS. This is ventricular activity. So this is called as ventricular tachycardia. So normal, normal, abnormal QRS, no T wave, no time for repolarization. It's just firing bang, 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 bang. And then suddenly it's come back to normal. So this is ventricular tachycardia. Okay. Look at this one. Again, same thing. It's represented in a 12 lead. Lots of abnormal things happening, but the rhythm looks normal. Can you see that? The gap between two QRS is normal. The same. So the distance between the QRS is normal, but a lot of ventricular activity is happening. Is repeatedly firing. There is no P wave. You cannot see a P wave on this. The QRS is regular. The rate is 200 beats per minute, but the QRS is broad, almost 280 milliseconds. If you calculate from year to year, it will actually calculate to 280 milliseconds. And the shape is not normal. This is not a normal shape. And so that is why, and also there is no time for repolarization. Even before it can repolarize, it's firing another QRS. So QRS called as ventricular tachycardia. Okay. So this is classical ventricular tachycardia, but this is not returning to sinus. Okay, the previous one returned to sinus. This is not returning to sinus. Let's look at the next one. In this one, there's chaotic rhythm. There is QRS all over the place, and then the gap is increasing. Look at this. The gap is increasing. Don't know which one is ventricle, which one is atrial. The rate is chaotic. You cannot even calculate the rate because you don't know what is happening here. There is no P wave. I can't see a P wave on this at all. There is no P wave seen. So I cannot calculate the PR interval. The ventricle is firing bang, 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 bang. And the ventricle is firing at an abnormal rate. It is continuously firing, but abnormal, not in a rhythm. And this is classical ventricular fibrillation. The QRS is some places absent, some places present, completely chaotic. This is ventricular fibrillation. Okay. So this is classical of ventricular fibrillation. What happens is multiple foci on the ventricle start to fire at their own rhythm. So one fire, then the second one fires, third one fires. The P does not have time to do anything. And this is a very bad situation. The patient is going to die in this situation, okay? Because ventricular fibrillation means if you do not defibrillate this guy, or if you do not convert him to sinus quickly, he's going to die because his ventricle, the heart cannot function like this, okay? So look at this one really quickly. Sinus rhythm rate is 125. There is evidence of right axis deviation. There's a short PR interval, but the important thing is there's a slurred uptake. See this? See, this is classical. Can you see this? I'm not wasting time on the rate and things like that, okay? Because I've already discussed this with you. Are you okay with that, guys? I want to finish.
Yes, sir. Yes, sir. Yes, sir.
So I'm not wasting time on how to calculate rate or how to calculate deviation. But there is right axis there. But the PR interval is very short. Yeah, look at this. There is no PR interval. Can you see this? And the most important is this takeoff. As soon as the P is finishing, the R is taking off. As soon as the P is finishing, the R is taking off. Look at this. There's a slant here. There is no PR. The PR is shortened. There's really a problem with PR. See here. As soon as the P is finishing, the R is taking off. As soon as the P is finishing, the R is taking off. This is a conduction problem. The atrium is firing because you're seeing the P. The atrium is firing. The ventricle is firing, but the conduction is abnormal. Something is wrong here. And this is classically called as delta wave. This takeoff with a very short PR, this curved takeoff is called as a delta wave. And whenever you see a delta wave in any of the leads, okay, look at V3, V4, there is delta wave here. Whenever you see a delta wave, there is only one diagnosis, and that is WPW, okay? Wolff-Parkinson-White syndrome. So remember that delta wave is always in WPW. Why does that happen? Because there is a re-entry tachycardia. There's an abnormal focus. So as soon as this goes through, that focus comes in and tries to take over. So there is what is called as a re-entry tachycardia. Okay? So there's an abnormal focus and a re-entry tachycardia, which creates the delta wave. Let me analyze this for you. The rate is 84. The rhythm is sinus. Yeah. AV association. Okay. So P is followed by QRS. That's what we mean by AV association. Look here. The P is followed by QRS. That's okay. The PR is very short. Can you see that? PR is very short, very short, very short PR. There is no QRS. See, very short PR. QRS is widened. There is a widened QRS in this. Yeah. And slurred uptake. Again, slurred uptake. Look at this, slurred uptake. Slurred uptake. Yeah. Again, see here, slurred uptake. Slurred uptake. So there is a slurred uptake, particularly V3, V4. If you see, this is V3. Slurred uptake. Look here carefully. Slurred uptake, slurred uptake. This is again classical of WPW. Okay. So this is how it will be thrown to you. So what happens in a WPW is that there is re-entry through a bundle of, there's something called as a bundle of Kent. So the atria fires here, comes in and goes down here, but the bundle of Kent fires another one. And so there is what is called as a re-entry rhythm, and the re-entry rhythm does not give time for the ventricle to fire to depolarize. So that's why there is a change in the thing. Again, I'm not here teaching clinical side. I'm not here to teach you about WPW, but I just want you to understand a little bit of these concepts. The important thing of WPW is that you should avoid adenosine. You should not think this to be an SVT, because the moment you put WPW and you give adenosine, you will cause complete heart block. So you should not give adenosine, should not give beta blockers, should not give calcium channel blockers, and certainly should not give digoxin. The treatment for WPW is amiodarone. Okay, so that is why it's important to differentiate what is the rhythm abnormalities that you are facing. Just really quickly, one or two more. I'm almost finished with rhythm issues. So this is occasional P waves, not related to QRS. But look at this. What are you seeing here? This is important. See this? What is happening here, guys? Look at this. So this is P wave, but there is some spike here in the QRS. Every QRS is having a spike. Can you see that? Every QRS has got a spike. So what the hell? Why is the QRS spiking? The QRS is spiking because you are making it spike. This is a pacemaker stimulus. The pacemaker is controlling the ventricle, and every time the P wave contracts, the pacemaker then stimulates and you get a spike. This is called as pacemaker stimulus. Okay, so you can have ventricular stimulation, you can have atrial stimulation. Depending on what you want to do, you can stimulate whatever you want. The treatment of rhythm is underlying cause you have to treat. Extrasystole does not need treatment. If you have got acute heart failure or low blood pressure because of the rhythm, then you have to cardiovert. Cardiovert is the treatment. When you have got, the patient is compromised and the rhythm is affecting the blood pressure, you have to cardiovert the patient. If the patient is going into bradycardia, atropine is the answer, or pacing is the answer. You might have to pace the patient, okay? Abnormal tachycardias, you can try carotid sinus massage. Sinus tachycardia, SVT may slow down. If you try a carotid sinus massage, you may be able to slow down things, but in an atrial flutter, you will increase the block. Okay, the block may become worse. So be careful when you are doing this. You have to know what is the answer. If it is AFib or VT, there will be no effect by your carotid sinus massage. And if you think it is a supraventricular tachycardia, try adenosine. If it's a wide complex, you can give lignocaine. And this is the kind of chart that you follow whenever you're trying to diagnose rhythm problems in the heart. Thank you, guys. I'm going to stop here. I went a little fast at the end purely because I wanted to finish the rhythm. If you want, next time we can restart the lecture with the rhythm and go a bit slow and take you through all of the rhythms. Okay, that makes sense. Let's switch off the recording. Give back the control to me.
Yes, sir. 1 minute, sir.
Okay, let me just stop recording. Okay, thank you very much, guys. Give me some feedback. This is not an easy topic. It's a difficult topic, but it is something that I tried to sort of make it palatable for you guys. So I spent more time, and I went very slowly with the first part because it was important to understand exactly what was happening in the PQRS T segment. Okay. All right. Because give me some feedback, because this is a different way of teaching ECG.
No, this is definitely making sense, sir. This is
One minute,
definitely
one
good.
minute, because one minute. Wait, 1 minute. Yeah. Let me just stop the live transmission as well.